Hello, everyone, and welcome. We are going to be talking today about the Early Start Denver model and what makes up this model. My name is Melissa Mello. I'm a board-certified behavior analyst and one of the lead trainers at the UC Davis Mind Institute. The Mind Institute is a collaborative international research center committed to the awareness, understanding, and care of neurodevelopmental disorders. And it's one of the research centers where a lot of the work on the Early Start Denver model is currently being done. The main developers of the Esdm are Dr. Sally Rogers and Geraldine Dawson, and they worked together to develop an early intervention model that would address the needs of young toddlers with ASD. Dr. Sally Rogers is still at the Mind Institute today, and Dr. Geraldine Dawson is working on the East Coast at Duke University. So we're going to talk now about what is the Esdm and what makes up this model and why is it different from other models, other early interventions for young children with ASD. The Early Start Denver model is a naturalistic developmental behavior intervention, also called an NDBI. And by this we mean that it is data-driven, has a strong foundation in applied behavior analysis. The Esdm has a focus on a high rate of teaching, and we want to embed many learning opportunities inside every interaction that we have with the child. The Esdm is also manualized and curriculum-based. The curriculum contains many different developmentally appropriate skills across a wide variety of domains. The Esdm also utilizes response to intervention, meaning that if a child is not making progress on their goals or in their program, we want to make changes to their goals or to their program to ensure a fast rate of progress. The Esdm also focuses on the interpersonal exchange and shared affect between child and adult. Social communication is embedded inside all of the interactions that we engage in with the child. The Esdm is also called a routines-based teaching intervention. This means that the teaching takes place inside play routines as well as daily routines. So we are not only teaching during play, but inside all of a child's daily activities. There is also a focus on shared engagement inside joint activity routines. And we'll talk more about joint activity routines later, but they are the context within which all of the teaching occurs inside the Esdm. These joint activity routines occur both with and without objects. In the Esdm, when a joint activity routine occurs without objects, we call that a sensory social routine. Parents are active participants inside the Esdm and play a big role in their child's treatment. And the focus is on children with autism ages 12 to 48 months. The Esdm also contains a manual and a curriculum checklist. The manual outlines how to use the model to support young children with autism, as well as the theory. And the checklist gives you a way to assess the child's strength areas, as well as their weakness areas, and give you a roadmap for teaching. And we'll talk later about how to use that checklist to develop a child's treatment plan. The Esdm also contains a Fidelity tool that lays out how to teach using this approach. The Fidelity tool allows the interventionist or the therapist to know what techniques they should be utilizing to help the child be successful in their play interaction. The Fidelity tool is made up of many items all rated from 1 through 5, 1 meaning a low fidelity item, 5 meaning meeting fidelity. And they range from many different items, including focusing on child attention, dyadic engagement, which we also can call turn taking, the use of joint activity routines, so how well did the adult set up all 4 parts of that routine, child motivation and choice, embedding high rates of teaching into every activity that we perform with the child, focusing again on communication, especially that social communication, using positive affect, supporting the child's transition, as well as general teaching techniques such as prompting, chaining, shading, and fading. When we use the Fidelity tool, we are rating the interventionist's ability to use these techniques to help the child be successful in interactions. We also rate the therapist's ability to modulate affect and ensure that the child is not displaying any difficult or challenging behaviors during the session. So there are several variables that define the Early Start Denver model and separate it in some ways from every other intervention for young children with autism. And I'm going to talk you through the main features that define this model now. An important feature of the Early Start Denver model is that the model is based on a developmental framework. It is grounded in research in how typically developing children grow up over the first 5 years of life. In the Early Start Denver model, we understand autism as a developmental disorder that affects virtually every area of a young child's development. Not only social interaction and communication, but also motor development, imitation, as well as adaptive skills. So in the ESDM, we target all affected developmental areas. So wherever a child is behind compared to their peers, we are going to write treatment objectives and help them acquire needed skills to accelerate their development. Developmentally, we want to see our children affected by ASD come closer and closer to their typically developing peers. We know from research on infants and toddlers that they are experiential, hands-on learners. They learn from an activity through all of their senses. They learn from visual information, auditory information. They learn from the touch and feel of what's happening as action sequences play out in their routines. And we want to capitalize on the multimodal learning abilities of young children with autism. We don't want to restrict them to focusing on just one thing at a time. We want them to be able to bring in all of the learning information that's available in a routine so they can learn as rapidly as possible. We know from research on infant and toddler learning that the quality of a child's relationship with caregivers and other adults has a significant influence on their speed of learning and their willingness to imitate them and want to be like them. Secure, high-quality relationships with sensitive and responsive adults is important for children with autism as well. And this is important because an infant or toddler who is comfortable and wants to be near a caretaker is getting more learning opportunities. In ESDM, we seek to create that type of relationship between a therapist and a child to support child proximity and pleasure in the interactions, which will then allow for more learning opportunities. We also know that young children learn the most from routines of everyday life. That's where language and meaning are embedded in experiences that they learn over time. We want everyday infant-based learning for children with autism to also be based in routines, such as mealtime, hand washing, and bath time. Another principle of infant-toddler learning that we build on is a principle from the Russian psychologist Vygotsky. He talked about the fact that children are most ready to learn a skill that is just beyond what they can already do. He called this the zone of proximal development, and ESDM and the curriculum tool help us identify these zones so we know right where to work to support our children's learning at an optimal level. So we can think then of autism as something that impedes a child's social learning. If we think about children who are missing out on social opportunities because they're looking at a piece of carpet or staring at a ceiling fan, they're missing a lot of opportunities to engage in the social world with peers, with their family members, and with other people. And over time, we know now that the brain engages in this process called pruning, where parts of the brain that aren't being used don't get developed over time and don't function in the way that we would want to see when those pieces are getting practiced and used over time. So what we want to do in the ESDM is start to bring children back into the social world so that they're engaging in all of the learning opportunities that are being presented to them in the same way that a typically developing child would be engaging in learning opportunities. So then how do we change the course of autism to bring children back into the social world? In order to teach a child about social life, we need to teach them all of the building blocks that they will need to have one. So here are those building blocks we need to address the deficits in social learning. The first one is social interest and preference for social interaction. And we've already talked about how the lack of preference for social interaction can begin to impede learning. Another one of these building blocks is imitation. And this includes spontaneous imitation of actions, body movements, facial expressions, and gestures. Imitation is an important tool in early development in which children can learn from watching what their peers are doing and begin to do what their peers do. As you can imagine, if a child does not imitate, many important opportunities to learn new behaviors are missed. Next, there's joint attention and nonverbal communication. There is a whole world of nonverbal communication that babies and toddlers engage in. We refer to these behaviors as talking bodies. We understand that these early nonverbal skills are the platform on which early language is built. So quite often in the ESDM, we might work on earlier skills, such as the use of gestures, so that children have strengths in these areas to build more difficult language later upon. And language is really the heart of ESDM. Verbal and nonverbal communication skills are delayed in most young children with autism. And if that is not affected, that is one of the best predictors of better outcomes in adulthood. We consider the development of a useful communication system to be the most important thing that we can provide children. And finally, we think of functional and symbolic play as another important building block for social learning. Play is where children practice many of the social interaction skills that they will need in life. If young children with autism are going to develop strong peer relations, they've got to be able to learn how to play with other children and with the toys and props that children their age use. So our goal with this intervention is to strengthen the social reward value, increase social skills, increase the learning rate, and to prevent further alteration in neural and psychological development. We want to return children to the same learning trajectory as their typical peers. We want to bring the child back into the social world for all of their waking hours and to teach them the building blocks of social interaction. And finally, for whatever delays they already have, we are trying to fill in those gaps fast before they get any older and the gaps get any bigger. It is much easier to fill in a 6-month gap than it is to fill in a 3-year gap. And since children are already behind, we need to provide frequent learning opportunities to increase these learning rates. And the idea with Esdm is not to fully change autism or have someone leave the autism spectrum. We support the differences that autism can bring and the strength that it has. What we want to do is improve an individual's quality of life and make sure that they're able to access all of the parts of life that feel important and meaningful for that individual. In order to create these kinds of learning experiences and to have young children with autism inside the social life of the family and other environments through their waking hours, we have to maximize their learning opportunities by having them involved in routines everywhere. So inside the Esdm, you will see a lot of emphasis on routines of daily life activities, like going to the grocery store, taking a bath, getting dressed, diaper changes, going outside to water plants, swinging on swings, taking a walk, or feeding household pets. All of these activities have very rich learning opportunities for children, and so will help a child with autism understand what's going on in everyday life. And this is a part of why having the parents involved in treatment is so important. For children who are getting a low amount of service hours per week, having the parents understand how to deliver the intervention can help the child have a lot more access to learning opportunities and routines to engage in their daily life. We like to teach and empower parents to be able to utilize the teaching techniques in everywhere that they may be engaging with their child from morning till night, so that we're filling that child's day with social opportunities, opportunities to respond and learn. And we have a few different ways that we deliver the Esdm so that we are ensuring that we add a lot of treatment time for the child, even if that means the one-on-one intervention itself is low. So one of the ways that we deliver intervention is through a combination of parent coaching and one-on-one intervention delivered by paraprofessionals. The one-on-one intervention is usually delivered in children's homes or sometimes in a clinic, and this can be done from anywhere between 5 up to 20 hours or so per week. And we call this the intensive teaching model. In this situation, parents are learning the principles of the Early Start Denver model and applying those principles in daily routines at home, and the people who are working with the child are applying those principles in the clinic or home setting as well. So in this model, the child has a one-to-one interventionist working with them for some of the time, but then we're also meeting individually with the parent to ensure their skill use of the Esdm and teaching them how to incorporate techniques inside the rest of their day as well as their child's day. We've also figured out how to deliver Esdm via telehealth, and that's something that we are offering to children and families at this time as well. And there's no prescription on how many hours the child has to receive to be participating in the Esdm or to make progress. We've seen some nice progress with children who are receiving 5 hours a week, so there's no demand for a certain amount of hours. What we want to be doing is empowering parents to embed the Esdm into their day. Another way that we deliver the Early Start Denver model is by parent coaching only. Just like there's a manual for the Early Start Denver model itself, there's also a manual for parent coaching. It's a yellow manual, and it was developed to support parents in their use and their learning of the ESDM. When using the parent coaching approach, parents learn to implement the ESDM, and we have some nice research to show that parents can learn to teach the ESDM to their child at Fidelity. They learn how to embed learning into their child's everyday life, and they learn how to use the ESDM inside many different environments. The manual is broken down into a series of topics, and parents get to pick the topic that feels the most relevant to them as a starting point. The topics include things like language development, joint activity routines, managing challenging behavior, and taking turns and sharing inside of an ESDM activity. Inside coaching, parents are generally given a bit of didactic information covering the topic for the week, and then they're asked to engage with their child practicing that topic. So if their topic is communication, they might set up an activity that they know their child is interested in participating in, and start the activity and work on the communication techniques that the coach and parent developed together. As the parent interacts with their child, the coach might give a couple suggestions for improving the interaction, and after a few minutes of play, the parent and coach will debrief together and review how that session went. They might make some minor changes or suggestions, and then ask the parent to try again. And we continue this way until the parent is feeling comfortable with that topic. We'll review and discuss how to practice that throughout the week. And then the next week when the parent and coach meet, they'll review that topic, check in on progress, and begin the new topic. The idea is really to empower the parents and have them feel like they can be successful with their child with just a little bit of support. So it's a very hands-on model. And the final delivery model for the ESDM is what we call group ESDM or GESDM. And just like the parent coaching model, the group ESDM has its own manual that lays out exactly how to run these types of groups and these types of interventions. In the GESDM, or the group preschool delivery, children are generally present in a small preschool classroom from early morning to evening. Children will have the opportunity inside these groups to work in either small groups, which can consist of anywhere from 2 to 5 kids, upward to large groups, which may consist of 10, 15, or 20 kids. This model is teaching children to interact in group settings and prepares them for education later on. Many staff members work to help the groups run smoothly. Some staff members are called the lead interventionists, and each child in the group who has an ASD diagnosis and is getting GSDM has a lead staff member who is responsible for running that child's curriculum checklist. And the curriculum checklist is ran just like it is in one-on-one intervention. So every 12 weeks, that lead will do a checklist for the child and then develop that child's objectives. Those objectives will then be taught inside those small and large group activities. So they may cover anything from having a snack in a group setting, sharing and turn-taking with peers, and being able to attend and look at the adult in a larger group setting. Generally, though, there are not many differences other than the other kids present in how the ESDM is run in a group format rather than a one-on-one format. Along with that lead adult present who's running the child's program, there's also support staff. The lead's job is to let the support staff know what amount of support is necessary inside of each activity. So if the adult and child were running a small group activity, the lead might be the one who is in front of the children, leading the activity and setting up their learning opportunities, and the support staff would be behind the lead, ready to get direction on how to proceed with getting the children to attend. So based on the lead's description, the support staff might give prompts or offer other supports if that is what the lead has asked for. We'll talk now a little bit about some of the data that we have to support the use of the Early Start Denver model. There's much more data than we're going to review here. And if you're interested in the data, you can go to esdm.co and you can find a list of all of the publications that we have on that website. So oftentimes we do get asked, what makes the ESDM so special? What makes it different from other models? And along with the unique intervention approach, the other answer is the data. The Early Start Denver model has conducted multiple randomized controlled trials, which is the gold standard of research, to see how well the intervention is working to support the growth of young children with ASD. And the papers that have come out on the Early Start Denver model are demonstrating that the children who are receiving the intervention, at least in the research studies, are having very good outcomes. This first paper that was published by Dr. Geraldine Dawson and Sally Rogers, and from the University of Washington, where that first randomized controlled trial of the ESDM was conducted. Dr. Dawson and her coworkers conducted a randomized controlled trial in which 48 children with autism between the ages of 18 and 30 months were assigned to either receive Early Start Denver model intervention or to treatment as usual in the community. Children in the ESDM group received 15 hours a week of one-on-one therapy, as well as parent coaching every other week. Children who were from the community group received whatever community intervention was available in the area at that time. So this generally looked like an in-home ABA company who was also delivering treatment for about 15 hours per week, and that treatment was usually based on applied behavior analysis and some form of discrete trial teaching. Children stayed within the study in their assigned group for 2 years. They were evaluated every year to look at their learning rates, their language abilities, their social skills, their self-care skills, and a number of other dimensions of their development. And this paper got a lot of press, partly because randomized controlled trials are very rare in early intervention studies of autism. They are difficult to do and they are expensive, but also because of the number of significant differences that were found between the two groups of children. So on this slide, you can see that at baseline, the children were very well matched on IQ, and that's the scale along the left side of the graph. Both groups of children have an IQ of around 60 at the start of treatment. And that's a pretty typical IQ range for children who are an average of 24 months with autism and without other medical or genetic conditions, which was how this group was defined. A year later, on the IQ, the children receiving the Early Start Denver model had gained about 17 IQ points, where the children in the comparison group had gained about 5. And that represents a statistically significant difference. And another year later, the children in the Early Start Denver model group now had a mean IQ of about 80, no longer in the range of intellectual disability, while the community group, as a mean, had an IQ of 66, a 6-point gain over their initial scores. And surprisingly, the number of hours of intervention that these two groups received was very similar. The community children received a lot of intervention as well. They were in community preschools and they were receiving special services for autism. They were in speech therapy as well as occupational therapy, but they didn't make the kind of progress that children in the ESDM made. And this is something that we've seen in other studies as well. Children getting an eclectic range of interventions tend to not make as much progress as children getting a focused, very carefully manualized and organized intervention. The graph on your right represents the language development in these children, and we see a very similar picture to the IQ changes. We see on the scale that the average score is around 50. Both groups are clustering at about 25 on the T scores for the Mullen receptive language. We see 1 year later, the ESDM group is doing better than the community group, but there's not yet a significant difference. However, at 2 years, there is a significant difference and quite a bit of improvement in the children receiving ESDM compared to the children in the community group. We found this for both expressive and receptive language development. We saw similar gains as well on the Vineland scales on the overall functioning that children showed in everyday life at home and in the community routines when compared to their typically developing peers. The children with ESDM show significant advantages compared to the community children in adaptive behavior, receptive and expressive language, and in IQ scores. The study was then replicated to see if these results can maintain. In this replication study, 118 toddlers, ages 12 to 30 months, from 3 different sites were randomized. Again, they were randomized into either ESDM treatment or whatever community treatment was available in these 3 areas for those children. The hypotheses were that children in the ESDM group will make significant improvements in their language skills. It was also predicted that their ADAS severity would decrease and that children in the ESDM would generally have an advantage over children in the community groups. And we saw similar effects for language in this replication study, that children in the ESDM group tended to have improvement in their language over children who were in the community group. We're going to talk now about how to use the ESDM curriculum checklist to develop the treatment plans that you will follow as you use the Early Start Denver model. It's possible that you've been in settings before where you've had to develop treatment plans or objectives or something similar for children with ASD. And unfortunately for many of us, these experiences can be challenging. And in the ESDM, we're hoping to change that and make the flow and the purpose feel more functional for young children with ASD. The tools that are available for this process are the Blue Manual, the Early Start Denver model for young children with autism, and the curriculum tool which accompanies it. The curriculum checklist provides you with items that you're going to assess the child on and lays out the developmental domains in all areas. It helps us to understand what the child can do now and where they're headed next. The Blue Manual defines each of the items in the checklist and also tells you in detail how to administer it. The curriculum is divided into roughly the domains that we see in child development between the toddler and preschool period. There are 4 levels, and on each level, there are receptive and expressive domains, fine and gross motor domains, social interaction, cognition, play, and adaptive behavior. Other domain areas like imitation or joint attention or pre-academics come in and out at the level at which they're appropriate for a typically developing child. The 4 levels organize all of these domains according to what we expect to see in about the 9 to 18 month period for level 1, the 18 to 24 month period for level 2, the 24 to 36 month period for level 3, and the 36 to 48 month period for level 4, roughly. And this checklist is to be administered every 12 weeks for the child receiving intervention. So every 12 weeks, we're going to redo the checklist to come up with where the child is performing now. Where have they made progress? What are their new strengths? And what are their new challenge areas? And when we do the checklist, we want to be checking in with parents, asking them what their goals are for the child so we can ensure to include their goals in our treatment plan. If it happens that the parent goals don't exactly match up to where the child scores on the checklist, we can show the parents how we're trying to incorporate their goals into the treatment plan by working on a smaller step that is going to get us to that bigger goal where the parent wants to see their child. For example, if a parent says they want their child who's currently nonverbal to speak in full sentences, we might show the parent the checklist that we're working on starting to use sounds and individual words inside play, and that this is going to build us up to the parent's goal for their child. So what does the setting for the assessment look like? It's not set up like a typical standardized test, because this is not a standardized test. This is a play-based assessment in which we want to be in a friendly, child-type setting with toys around, child furniture, and the parent in the room with us. We want to work our way through a set of play activities in which the child can grow increasingly comfortable playing with the parent, playing with you, playing with the caregiver, and inside these play activities, we want the children to start to reveal their skills. So this may mean that we have a couple activities out on the floor, and we're going to see what the child gravitates to first. As they gravitate towards some activity, we're going to begin to interact with them. And so you're going to be walking into a room that's already prepared with some interesting materials. A child starts to play, and you join the parent or the child in whatever that play is, in whatever is beginning. And as that child starts to play, you just play along, and you find ways of doing little probes for language that they're using in their play, for the motor skills that they're using in their play, for the symbolic or constructive play skills that they're demonstrating, for the social reactions they're having to people and the cognitive concepts that underlie what they're doing. And you'll do a little piece of play with the child, 10 minutes or so maybe, and then as parent and child are sitting with the materials, you'll pull your curriculum checklist out and you'll score along in terms of what you've seen so far, the items you haven't seen, and then you wait to start another piece of play. And as you start that next play activity, you'll try to assess the items that you haven't seen yet until you've completed the curriculum checklist in its entirety. You'll follow through for about an hour and a half or so proceeding in this way, talking with the parent, watching what the child is doing with you and with the parent, and gathering the information that's available to you about what the child can do on the curriculum items that you're assessing. When you're completing the curriculum checklist, we want to see that the parent has been involved in the activities that we're assessing. So we're going to ask parents what they know about what their child can do. As we're performing skills, we're going to ask them, have you seen your child do this before? And then we're going to rate their responses on that curriculum checklist. The way that we rate responses is a plus if the child's performing the skill, a minus if they're not, and a plus minus if they're able to perform the skill sometimes but not others. You'll see that there's an observed column, and we want to fill that column out in its entirety. Then we want to also incorporate parent perspective when we can. Oftentimes this is when we might be struggling to get a response from the child. We'll ask if the child is able to perform the skill at home, or for some of the skills that are more difficult to address during an assessment, such as bathing or dressing. We might get the parent input on how they tend to do these skills. And then you'll see that there's another column for other clinician report. And in this column, we want to include any information we might be able to get from SLPs, OTs, anyone else who works with this particular child, and see how they experience the child performing the skill. And then in that last column, you'll see where we summarize all of the information that we've observed ourselves and collected from other people. We then use this curriculum checklist tool to develop the child's objectives. So all of those categories that we've now marked as a plus minus or a minus are going to become our child's treatment objectives. And we know to stop assessing in a particular domain because we've reached 3 minuses in a row for that particular domain. And it is totally okay if a child is working across multiple levels. So it may be the case that the child has stopped in level 1 for their communication, but has gone on to level 2 or even 3 in their motor skills. We just assess until we reach the stopping point of 3 minuses in a row. If you like to keep going to gather more information, that's fine. But once you have 3 minuses in a row, we have a ceiling and we consider that our stopping point. To write our objectives, we want to pick a minimum of 1 objective from each domain, even if the child is receiving a low number of treatment hours per week. So even if the child is receiving 1 or 2 hours of treatment a week, we still want them to have objectives in their fine and gross motor domains, in their expressive and receptive communication domains. Typically, we'll have 2 objectives from each one of those domains, as well as their play, imitation, adaptive skills, joint attention skills, and all of the other domains. We have a very specific format for writing ESDM objectives, which is laid out in the treatment manual. We start with an antecedent, which is a description of what the adult will do to cue the child to respond. For example, if the skill was to give an adult an item, the antecedent might be when an adult holds out their hand and requests an item. The next piece is the child behavior, and this usually comes from the checklist. So what do we want to see the child doing? From there, we're going to write a description of what it looks like if the child is successful. So we want to see that the child hands over the item, and then we want a mastery criteria as well as a generalization criteria. We want to see that the child is able to do this over multiple days with a high level of accuracy, and to generalize those skills across multiple items with multiple people and with multiple different types of locations. When the child is able to perform these skills in all of these areas, we can consider it mastered. The objectives are also broken down into smaller, teachable steps. The objective, as you may recall, is written for the child to be able to master 12 weeks from now. So we don't want them walking in tomorrow starting on that step because it's going to be too difficult. So we break the skills down into their smaller teaching steps so that the child has a place to begin learning and teaching from right away. These steps break down the big goal into small parts that take little steps to getting the child towards where we want them to be in the next 12 weeks. So to get them there, we might be doing things like reducing prompts, adding steps, adding words, increasing the amount of time that they'll engage, or whatever it might be for that particular child to make progress in their domains. The next important piece with this tool is that we are taking data on all of the child's objectives. This data is an important piece of using the Esdm and is how we're going to know if the child is making progress and if we need to make changes to their treatment plan in order to help the child be more successful in their skill building. Next, we're going to talk about joint activity routines, which are the framework for teaching inside of the Esdm. So first, let's think about what do we mean by this? What is an activity? What is a joint activity? An activity means that there's energy being put out, that the two partners are moving and doing, and that there's a liveliness to the activity. The child is having a hands-on learning experience that the adult is also participating in. The two of them are building an organized set of actions, and that's the routines part. There is an order to this, and it's going to come about as you describe. The order is something like first this happened, then this. There's a goal, and there's a directed activity. If it's an action with objects, the child has a goal in mind for what to do with these objects. If it's an interaction that doesn't involve objects, then the goal may be having fun, doing a song together or a dance together, chasing each other. But there is a goal. It's always a goal-directed activity. And we want to make sure that either the child understands our goal or that they have a goal and we understand it. Inside of this joint idea, we're sharing materials with the child, looking at each other, working back and forth, building on our communication and each other's ideas. So both the child and the adult are contributing ideas to the activity and building on them as we create something more advanced for learning. Finally, with energy and a goal is effort. It does require a little bit of effort for the child and adult to pull this off. It's not a relaxed way of teaching. It's very hands-on, and effort is put forth on both ends to reach your goal. However, it should be fun and engaging and utilizing the child's interest and motivation to keep the teaching moving forward. A joint activity routine involves 4 easy steps. The first step is a setup. We want to have a clear setup from the beginning of the interaction until the two partners land on a theme. So the setup is figuring out what it is that you and the child are going to engage in. It might mean that you offer a couple different activities until we see which one the child is interested in and wants to land on. Inside of the setup and inside of every piece of the joint activity routine, we want to be embedding learning objectives. So the setup might be a very nice time to offer choice to the child and have them point to an activity if that is their goal. So we might hold up a shape sorter and a ring stacker and ask the child which one it is that they want to do. And as we start figuring out how we're going to interact with those materials, we find ourselves in the theme. And the theme is really just, what are you doing? What are you doing with this activity? The setup leads to a theme, and the theme might go back and forth a few times with both partners involved. And this is just really how the child has decided they want to first use this activity. So it might be that you're putting the shapes into the shape sorter, but themes can get repetitive, and we can find a place where there's no more learning to be gained when a theme becomes too repetitive. And so what we want to do then is to offer variations. Variations extend the activity, they allow more language to occur, and they allow more objectives to be taught. They keep the activity stimulating and interesting, and brings the child's curiosity up. Variations also require the child to be flexible in their play and should introduce more and more ideas for what to do with this object. And this is good for children, especially with autism, who tend to be not so flexible with their play. It might be at first that the theme or the variation is brief as the child is getting used to using activities in new ways, and that's okay. We're just going to keep exposing them to the variations until they've become more comfortable. And we can always go back to the theme and then back to a variation so that the child is back to their comfort zone and then back to being pushed a little bit. And finally, as someone is running out of ideas or energy for the activity, it needs to be closed down. But we want a nice, orderly closing. We don't want children just walking away or escaping from the activity. We want a decision to come that we are finished now, that we're going to put this away and we're going to start something else. So we want an organized closing and a clear transition to another activity. And again, inside of the closing, we want to see objectives being embedded. This is often a time for the child's matching skills to get worked on, as they can match or sort items as we clean them up. But inside of each one of these 4 steps, we're embedding a lot of learning opportunities for the children to engage in. And in the ESDM, we talk about 2 different primary kinds of joint activity routines. One of these involves play with objects. The advantage of doing an activity routine involving objects is that they give you setup and allows you to work on joint attention. In play with objects, you have 3 points of contact, that triangle of joint attention: the child, the adult, and the object. And that triangle of attention is the framework for working on joint attention behaviors, such as sharing, giving, pointing, and commenting. That all-important skill, both at the nonverbal and verbal level, is such an important scaffold for language development and is so difficult for young children with autism. Play with objects is kind of our more formal framework for teaching joint attention. The other kind of critical joint activity routine that we practice in the ESDM is called a sensory social routine. These are routines in which the objects are not as important. What's really important inside a sensory social routine is the dyadic exchange between 2 people. These are routines in which people are face to face. The child is giving you a lot of eye contact with a lot of facial expression, shared smiles, laughter, pleasure, reaching out to make things happen. The strength of sensory social routines is this dyadic interaction. This really highlights how 2 people communicate face to face. All the information is in the face and in the gesture, and children are captivated by the physical presence of the partner. These 2 kinds of joint activity routines together highlight the key areas of social learning that young children with autism need in order to move forward with their communication development. And in the ESDM, we want to be moving back and forth between these 2 types of joint activity routines. We want to be offering routines with objects as well as sensory social routines so that the child is getting practice in using their skills in both types of environments, both routines, activities-based objects, and social routines. The last thing we'll talk about in regards to the Early Start Denver model is how to make changes to a child's program if they are not progressing in the way that we would expect to see. We mentioned before that we're expecting to see a high rate of progress and that we take data to ensure this is happening. And if our data shows us that we are not getting that rate of progress, we're going to respond. What makes the ESDM such a comprehensive model is that there is a guide for how to decide what to do if a child is not making progress. It's an essential part of the model that when a child is not making progress, we make changes to our treatment. We don't want to waste our treatment time trying to teach a child a skill in a way that doesn't work for them. So we're going to talk about how to use the decision tree, and in the English manual, this is on page 131. The way that we make changes to a child's program is using a stepwise approach. First, we begin with changing reinforcer strength. Most of the time, varying reinforcer strength and structure in a teaching situation will result in more rapid learning. But occasionally it doesn't, and then we bring in the third level of visual supports. Now there is a hierarchy here. Any visual support that you think will help the child learn the behavior in the presence of the antecedent can be used. And what visual supports you might use are many. You might use visual antecedents like a picture schedule. You might use an ABC schedule for a set of chained events. You might use visual cues like pictures or drawings or templates. You might use things like sorting boxes, perhaps the picture exchange communication system or sign language. Any visual support that you think will help the child can be used. Across all of these, if you've chosen the appropriate support, you should start to see some progress. When using the decision tree, you're not going to take away the supports that you need until the child has mastered that behavior. However, you're also not going to add these supports to other objectives that are going well. This is a specific intervention for a specific learning target that is not proceeding. We'd begin by looking at the reinforcement and seeing if the natural reinforcers being offered are not supporting child growth. From there, we would move down to adding extrinsic reinforcers, all the way to adding edibles if it's needed to see child progress. If we've made all the changes we can make inside the reinforcement column, we would move to structure and start teaching the skills in a different format, all the way to having the child seated, using a familiar format with the same materials and mass trialing those opportunities. And again, if we're still not seeing progress, we'll move to adding those visual supports. Thank you so much for joining for this talk on the Early Start Denver model and how to implement and use the model. I hope that it was useful and that you can take something to bring into your next session with a young child with autism to improve your interaction as well as their interest and motivation, and that you start to see some beautiful gains in the child that you're working with through the use of this model. Thank you so much and stay well.